Um, okay, let's get started. I'll do a time check. It's 2 p.m. in Singapore on Friday, August 27, 2021. And on behalf of the Singh Health Duke-NUS Global Health Institute, I'm delighted to welcome all of you. I'm Amina Mahmood. I'm the Deputy Director of the Institute, and this talk is today part of our monthly Global Health Seminar series. In these sessions, we draw from our faculty as well as guest speakers to present different topics of global importance in global health, and we engage with our community in Singapore and beyond. So I'm really delighted today have with us a very prominent and active SDGHI faculty member, Professor Piers Chow. He'll talk about the impact of COVID-19 on the management of hepatocellular carcinoma in Asia Pacific and lessons from the first wave. To introduce him briefly, though I'm sure a lot of you know his background, Professor Piers Chow is an academic surgeon and professor at the Duke-NUS Medical School. He's concurrently senior consultant surgeon at the National Cancer Center, Singapore, and the Singapore General Hospital. He's also an NMRC senior clinician scientist, adjunct faculty, and senior group leader at the Genome Institute of Singapore, and research director at the Institute of Molecular and Cell Biology. As you can see, he's a very busy man. He received his PhD from the National University of Singapore and has trained in liver transplantation with Professor Russell Strong in Australia. In 1997, he co-founded the Asia Pacific Hepatocellular Carcinoma Trials Group and has been on the protocol chair of 7 prospective multinational studies that have involved 54 sites in 17 countries and territories. So there's a rich data source that he draws from. He has won numerous awards, including the NMRC National Outstanding Clinician Scientist Award in 2012. This was for improving clinical outcomes with his research on liver cancer. In 2016, he was awarded the NMRC TCR grant for the flagship program in liver cancer. And in 2017, a BMRC IFPP grant to develop a patient-specific diagnostic and predictive platform for liver cancer. In 2020, he was awarded an A-star IASF ICP grant to conduct a national-wide cohort study to develop diagnostics for early detection of hepatocellular carcinoma in high-risk patients. So he's really kind of been at the leading edge for a long time. His talents extend beyond to academic education, and he's the inaugural program director of the PhD program in clinical sciences at Duke-NUS. So I could go on, but I'm going to stop here and hand over to him and say thank you to Piers for being with us today. Really looking forward to the talk. Before I hand over, a few housekeeping notes. Please keep yourself on mute the entire time. The webinar is being recorded, and please post your questions in the chat box at any time. They will be addressed at the end of the lecture. So over to you, Piers, and thank you again for being with us.
Yes, thank you very much, Amina, for your very kind introduction. Let me just share screen so that everybody can see the presentation. Yeah. Well, I hope you can see this. I'm very pleased to be here this afternoon, and I'd like to thank Amina and the organizing committee for inviting me to speak. The title of my lecture this afternoon is The Impact of COVID-19 on the Management of Hepatocellular Carcinoma in the Asia Pacific, and I'll discuss the lessons that we've learned from the first wave of this pandemic. These are my usual disclosures. In this talk, I'll firstly introduce the biology and epidemiology of HCC and its significance in the Asia Pacific. And then I'll describe how we responded to the first wave of the COVID-19 pandemic, and then the impact of that response on cancer care globally. I will also discuss how the COVID-19 Asia Pacific HCC survey comes about on the back of the HCC registry in the Asia Pacific, and then the results of that survey, the impact of COVID-19 on the management of liver cancer in the Asia Pacific. And then I'll also describe or discuss the lessons that we have learned from what we have found. Now, hepatocellular carcinoma or liver cancer or primary liver cancer is a very important cancer with more than 1 million new cases every year. Unfortunately, most of them in the Asia Pacific where we live. It is the 7th most common cancer worldwide, and also, unfortunately, the 4th most common cause of cancer death. And until recently, there has been very few efficacious therapies. Those diagnosed with early stage disease can hope for a potential cure, but at whichever stage they are diagnosed appropriately, treated, they can do well, but otherwise overall survival is extremely poor. Now, the main reason why HCC is more prevalent in the Asia Pacific is really because of hepatitis B. Chronic hepatitis B is the most important causative factor for liver cancer, and hepatitis B is found mainly in the Asia Pacific and accounts for more than 50% of all liver cancers worldwide. But there is a wide geographical variation. If you look at HCC from Korea, more than 70% of them are due to hepatitis B, but in Japan, it drops to 15% because in Japan, hepatitis C is more important. And hepatitis B as a cause of liver cancer is extremely rare in countries like Sweden in the West. And most patients get hepatitis B either through sexual transmission or through parenteral transmission. But in the Asia Pacific, where the virus is actually endemic, most patients get infected with hepatitis B through the perinatal course during the time they were born, because they get it from their mothers who are hepatitis B e antigen positive. Now, at the time that HCC is diagnosed, they are diagnosed at a wide range of the disease, and this is important to understand. As this data from the National Cancer Center Singapore shows, at the time of diagnosis, 22.3% of them are diagnosed at the early stage. Another 46% of them are diagnosed at the locally advanced stage, with 24% in the intermediate stage and another 22% with vascular innervation. And the last 31.7% are diagnosed with metastatic disease. It's important to understand this because the best treatment outcomes for HCC really depends on the choice of treatment modality appropriate for cancer at that stage. And this is really impacted on by COVID, because if you look at the appropriate treatments for the patients at the different stages, some of these treatments require that the patients be admitted to the hospital, be inpatients, for example, for surgical resection, for radioembolization, and so on. And even for systemic therapy, some of them can be treated with oral systemic therapy, which means that the patients can be treated as outpatients, whereas some of the more efficacious therapies may need patients to come to the hospital because the treatment has to be delivered intravenous. And later in our survey, you'll find the impact of this on how the patients are managed. Now, COVID-19 has a direct impact on the liver, and it can be a direct cytopathic effect. And in patients with chronic hepatitis C cirrhosis, there's a greater than 30-fold increase in the ACE2 expression in the livers of such patients compared with the healthy controls. And our own research from A*STAR and the National Cancer Center Singapore shows that there is co-expression of the angiotensin converting enzyme 2 and the transmembrane serine protease 2 in a specific TROP2 positive liver progenitor population of cirrhotic livers. And it suggests that the SARS-CoV-2 virus may preferentially infect TROP2 high cholangiocyte-based progenitors, thereby compromising the regenerative ability of the liver and contributes to liver pathology. How did the world respond to the first wave of the COVID-19 pandemic? Well, they say that generals tend to fight the last wars. And I think initially the world reacted to the COVID-19 pandemic as if it was SARS or MERS, two other coronaviruses that we are more familiar with at that time. SARS first appeared in November 2002, and by July the following year, WHO declared that there was worldwide containment. So it was a very short period of time. SARS infected 898 patients, killed 774 people. And when we were confronting SARS at the time, there was no diagnostic kit, no vaccine. The global case fatality rate is 11%, and SARS was strictly controlled with public health measures because there was no other treatment. And in spite of that, we controlled SARS within a very short period of time. Then in April 2012, MERS emerged, and of course, re-emerged a few times later, in total infecting about 2,574 patients, causing 886 deaths. At that time, there was a diagnostic kit for MERS, but no vaccine. The global case fatality rate was extremely high at 34.4%. But again, MERS was controlled strictly with only public health measures, and we managed to control MERS. So at the end of 2019, the COVID pandemic came about in multiple waves and is still ongoing. To date, it has infected 197 million people, causing 4.2 million deaths. And we have vaccines, we have diagnostic kits. The global case fatality rate is relatively lower at 3.4%. And we have to ask ourselves whether the strategy that worked for SARS and MERS in the past will continue to work for us in COVID-19, which is essentially a very different disease. And our experience at the Singapore General Hospital with SARS was very visceral, because at the time the SARS hit us, cases were initially defined according to syndromatic features in the absence of test kits, because we had no diagnostic kits, no PCR, no rapid antigen test, and of course there was no vaccine. And 76% of infections in Singapore were traced to hospitals, and about 46% of SARS patients were in fact healthcare workers. And SARS was very deadly. The case fatality rate in Singapore was higher than the international rate at 13.9%. And we saw healthcare worker colleagues dying from the disease. And within the SGH general surgery wards, an index case was traced, whose infection eventually led to 38 cases of SARS in healthcare workers, patients, visitors, and another 12 cases across the rest of the hospitals. And the important lesson we took from that was that drastic healthcare measures taken brought SARS under control within months without vaccines. And this very visceral experience shaped our initial response to the first wave of the COVID-19. So because up to 20% of patients with COVID-19 infections will require inpatient or intensive care or assisted ventilation, one of the first things we did was to defer non-urgent hospital visits to reduce footfall and also to reprioritize the resources of the hospitals. And in January 2020, we begin to defer non-urgent hospital visits. We later lifted that, but in May 2021, we had to reintroduce that again as COVID-19 cases rose dramatically. The question is whether it is sustainable to do that in the long run with multiple waves of the pandemic. The patients themselves deferred hospital visits due to their worries about contracting COVID-19 at healthcare institutions. And a study done in the US shows that half of the respondents were more afraid of contracting COVID-19 than experiencing a heart attack or a stroke. And there is data to suggest that cancer patients may be more susceptible. A meta-analysis performed in China showed an elevated case fatality rate of 5.6% for cancer patients. And across the world, there is reduced accessibility to healthcare facilities. Large countries like the US and China impose statewide or city-level restrictions, and the cessation of public transportation network during the lockdowns also contributed to this. What was the impact of the initial response to the first wave on cancer care globally? The impact was actually very drastic. So in April 2020, the American Cancer Society suggested that no one should go to a healthcare facility for routine or non-diagnostic cancer screening. And this was not lifted until April the following year, where the American Cancer Society suggested that we may restart cancer screening with careful consideration. And the American Society of Clinical Oncology guidelines in 2020 suggests that we should continue postponement of most cancer screening procedures. And taken together, all this resulted in a screening deficit and its downstream consequences. There is no doubt that COVID-19 disrupted care for patients with cancer. In this publication in JCO Global Oncology, it showed that an overwhelming majority of 88% of 356 sites faced challenges in providing the usual cancer care to patients. And some of the reasons were precautionary measures, overwhelmed healthcare services, staff shortages, lack of PPE, lack of medication, and other things. And in some hospitals, there was an outright stoppage of radiation therapy and also for systemic therapy. A very small study in Milan suggested that in 26% of patients with liver cancer, there was a delay in scheduled therapy. And two of my friends, Professor Stephen Chan from Hong Kong and Professor Kudo from Japan, wrote an opinion piece that suggested that in the pandemic, patients with early stage disease should defer surgery and to consider preoperative treatments, and that there should be an outright suspension of liver transplantation. They suggested that in intermediate stage HCC, standard of care local regional therapy should be replaced with oral systemic therapy, very drastic. And in advanced stage cancer, in fact, oral systemic therapy should be sent to patients by post so that they don't come to the hospital. And that for follow-up, we should actually use telemedicine. The routine workflow of liver cancer management is directly impacted by the COVID-19 pandemic. And the usual workflow goes like that. Patients who are at risk for developing liver cancer, such as those with chronic hepatitis B or cirrhosis, they should undergo routine surveillance with ultrasound examination and plasma alpha-fetoprotein every 6 months. And if either of them were to be abnormal, then they should undergo a diagnostic multiphasic CT scan or MRI. And if HCC is detected, then according to the stage at which it is diagnosed, it should receive the appropriate treatment. And you can see that COVID-19 resulted in severe allocation of resources that would directly impact on this workflow. Firstly, any deferring of non-urgent hospital visits will impact on surveillance, and sometimes there is total suspension of screening programs. And delays in diagnosis will result in later stages of the cancer diagnosis. And there are also delays in initiation of treatment. And when they are diagnosed, there are limited treatment options because of the late diagnosis. And patients who are undergoing treatment will also have interruptions in their treatment regimes. And there is certainly significant disruption to clinical trials. There's been reported delays in 16 clinical trials for HCC across phase 1 to phase 3. And our own experience at SingHealth has been similar. There's been suspension of all new or ongoing studies of clinical trials. There's been postponement of follow-ups. There's been suspension of all bench work. And during DOSCON Red, in fact, all research staff were deployed to various stations to assist in lockdown processes. The first case of COVID-19 in Singapore was diagnosed on 23rd of January 2020, and then the dormitory classes happened. So on April 18, we had the beginning of the circuit breaker, which was only lifted on June the 1st. And on June the 19th, we moved into phase 2 of reopening, and thereafter we start closing the major dormitory clusters. And Singapore moved into phase 3 on December 28th. And more importantly, on December 30th, we introduced vaccination for healthcare workers, and we extended that to seniors above 70 years old on February 22nd. But unfortunately, clusters started appearing again. And on May 16th, we returned to phase 2, heightened alert, which was lifted on June 13th. And then we returned to phase 2 again on July 20th, and this was only recently lifted. So if you look at the timelines of COVID-19 in Singapore alone, we can see that essentially it is more than one wave. It is not a pandemic that can be controlled within a number of months like SARS had been. And even with the introduction of vaccination, we'll still see a subsequent wave. So how does it pan out to patients with liver cancer? Right. So how did our COVID-19 Asia Pacific Liver Cancer Survey came about? This cancer survey was piggybacked on an existing registry study, the Hepatocellular Carcinoma Registry in Asia. And the HCC registry in Asia started in June 2016 and ended in December 2020. And the COVID-19 pandemic started towards the end of 2019. And because of that, there was an overlap between the start of the pandemic and the running of the registry. So what we did was to leverage on the resources we had on the registry in order to carry out a survey. And this registry was a large registry. At the time we closed, we have enrolled more than 2,500 patients from 33 sites. And this was run by a very established trials group, which has already completed 7 studies and with 3 other studies ongoing. The registry was started in order to collect real-world data because real-world data were important. for the development of effective public health strategies and also to inform the development of therapeutics. And in the registry study, patients are treated, managed, and followed up according to local clinical practices, and patient-reported outcomes are collected. So you can see there's an overlap between the start of the pandemic and the running of the registry. And because of that, we reached out to our trials group and asked for data from 2 periods of time. For a period of time in 2019, between February and May 2019, for patient data on HCC, and for patient data on HCC in another period of time within the first wave of the COVID-19 pandemic between February 2020 and May 2020. And the purpose of this survey was to evaluate the impact of the pandemic on the diagnosis, the treatment, and the consultation methods for patients with HCC during the initial wave of the COVID-19 pandemic. We reached out to 55 hospitals within our trials group and invited them, and we were very pleased that 27 of them replied because they were all struggling with COVID-19. And we managed to obtain data from 2 periods, February to May 2019 and February to May 2020. And the information collected included delays in diagnosis and treatment, changes in treatment modalities and complication rates, changes in patient enrollment in clinical trials, and modes of patient consultation. And importantly, all this data was stratified according to the BCLC staging system for HCC. And as a reminder, this is because the best treatment modalities, best treatment outcomes for HCC really depends on the choice of appropriate modality for that cancer stage. And here, because of the pandemic, we can see that there are lots of opportunities for this treatment to change in response to the pandemic. These were the data collected. So from the 27 sites that joined the study, we were able to get data from 2,789 patients in the pre-pandemic period and 2,045 patients in the first wave of the pandemic. And these are the hospitals that were involved in the study. The results of the survey were very illuminating and really describes the impact of COVID-19 on the management of HCC in the Asia Pacific. There was a very significant reduction in the number of new patients diagnosed. There was a decline of an average of 27.6 patients per institution comparing the pre-pandemic period with the first wave of the pandemic. And this decline was due to the suspension or deprioritization of cancer screening programs and appointments. And the greatest reduction came from Myanmar, Indonesia, Philippines, and very interestingly, also Hong Kong. There was no difference or change for Brunei, which is a very small country. But interestingly, in the only hospital that reported from Malaysia, there was an increase in the number of patients diagnosed. And this was from the Selayang Hospital, which was the National Referral Center for Liver Cancer in Malaysia. And we postulated that this could be because all the other hospitals, once they diagnosed liver cancer, may have sent them to Selayang because they were struggling otherwise to provide an appropriate service for the patient. 48.3% of the institutions reported delays in diagnosis of new cases of HCC because of the pandemic across all stages of the disease. And 62.1% of the institutions reported delays in initiating liver cancer treatment across all stages of the disease as well. But more importantly, we saw changes in the treatment modalities of this patient. 31% of the institutions reported changes in the treatment modalities of patients with BCLC 0 and A or BCLC B stages, and 17.2% of the institutions reported changes in treatment modalities for BCLC C. And BCLC C patients are treated with either oral or systemic therapy. So you can see how things may change. And it is important to remember that best outcomes actually comes from the most appropriately treated therapy. But many of these appropriate therapies may require inpatient stay. And for systemic therapy, some of them can be given oral therapy, or some of them has to be delivered by IV administration, which means the patient has to come to the hospital. And we'll see how this is impacted upon by COVID-19. On average, 46.6% of the institutions reported a decrease in the proportion of patients with BCLC 0A and B stages treated with elective surgery during COVID-19. And this is quite amazing because for patients with BCLC 0A, surgical resection is actually potentially curative. So we see a significant proportion of the institutions reporting that instead of giving curative treatment to these patients, the patients were given an alternative treatment which cannot be curative. So this is a huge impact on the management of patients with HCC. And of course, surgery, you need the patients to be admitted to the hospital. And for patients who need systemic therapy, there are currently 3 first-line systemic therapies. There is sorafenib, which is an oral therapy. There's lenvatinib, which is also an oral therapy. And there is the combination immunotherapy of atezo and bev, which is a therapy that is delivered by intravenous means, which means the patient has to come to the hospital. If you look at the randomized controlled trials that establish these therapies, the median overall survival with sorafenib is 10.7 months. The median overall survival with lenvatinib is 13.6 months. But by far the better outcomes will be the median overall survival with atezo-bev, which is 19.2 months. But to receive atezo-bev, you really have to go to the hospital, whereas oral therapy can be given as outpatient and the patient can be treated as outpatient. And what we found was that 41.4% of the institutions reported an increase in the proportion of patients with BCLC B stage being treated with oral systemic therapy. And this is very interesting because oral systemic therapy is not even first-line therapy in BCLC-B. First-line therapy in BCLC-B is local regional therapy like TACE or selective internal radiation therapy. But now patients are being treated with oral therapy because I think they can be treated as outpatients because of that and they don't have to come to the hospital. So there's a distinct change in the treatment modalities and patients are not necessarily being treated with the best modalities because of the contingencies of the COVID-19 pandemic. On average, 13.8% of the institutions reported an increase in HCC treatment complications because of the pandemic. And there was no growth in clinical trials enrollment. In fact, 86.3% of the institutions reported a decrease in patient enrollment in studies for BCLC 0A and B, and 31% reported a similar decrease for enrollment of BCLC C. And this compares the mode of consultation in 2019 with the corresponding period in 2020, corresponding to the first wave of the COVID-19 pandemic. And on average, there's a reduction of face-to-face consultation by 27% due to restrictions such as social distancing, home confinement, and complete lockdowns in some countries. And the highest adoption of teleconsulting was in the Philippines, in Australia, and in Myanmar, which was also very interesting because Philippines and Myanmar are third world countries, and they managed to do teleconsultation. How do these findings correlate with findings outside of the Asia Pacific? In the Netherlands Cancer Registry, there's a 27% decrease in cancer incidence. In the United States, there is a 46% decrease in the weekly cancer diagnosis. And in the UK, there is a 75% decrease in referrals for suspected cancers. And in the only other big study involving liver cancer, this was the European study done by Munoz-Martinez. And if we compare the European or Western study with the Asia Pacific study, in the Western study, 87% of the centers reported modified clinical practices. In the Asia Pacific, 31% of centers reported changes in treatment modalities for BCLC 0A and B, and 17% reported changes in BCLC C. In the Western study, 81% of the centers reported deferred screening programs. In the Asia Pacific study, 48.3% of the centers reported delay in diagnosis of HCC cases. In the Western study, again, 50% of the centers reported canceled curative and or palliative treatments. In the Asia Pacific study, 46.6% of the centers saw a decrease in elective surgery for BCLC 0A and B, and 41% of the centers saw an increase in oral therapy with BCLC C. and there was a delay in initiation of HCC treatment in 62.1 of the centers. There are, of course, some limitations to this study. There is a potential for systemic differences in patient profiles to be overlooked because of the aggregated nature of the data collection. And the small number of institutions may underrepresent the country or the regional demographics. And the survey provided mainly qualitative data, and there was no granular data on the individual patient. What have we learned from the first wave of the COVID-19 and the results of our study? I think, to quote the WHO director, history tells us that this will not be the last pandemic, and in fact, epidemics are a fact of life. And we found that the impact of indiscriminate postponement of clinical service can lead to drastically poorer outcomes, especially for cancer care. The current backlog of screening services will impact the healthcare systems significantly, and the cost of managing liver cancer will increase exponentially with later stages of diagnosis, with decreasing treatment efficacy. And we have to look at the risk-benefit ratios very carefully. And one of the things that we learned was something that we can share from the Division of Surgery and Surgical Oncology at the Singapore General Hospital. So the division undertook a policy of not postponing cancer surgery, and consultant-grade surgeons can decide on the postponement of non-cancer surgery based on ASA scores and based on comorbidities. And with this practice of calibrated reduction, if you look at the data between February and June 2020 and compare that to the same period in 2019, there was a very significant decrease in the monthly volume of surgeries. But if you come down on 4 index cancer surgeries for breast, colon, liver, rectum, the volume of cancer surgeries remained largely unchanged. So we were able to have a calibrated postponement of surgery, which allowed us to free up 6,640 man-hours to be reallocated to support COVID containment efforts without a significant increase in emergency surgeries. So a calibrated response to cancer care is actually possible. The data that our survey provided can guide healthcare systems on the continual assessment of the impact of their policies. And we know that COVID-19 is not going to be over soon, but the drastic short-term measures that succeeded in SARS are not tenable in COVID-19, which will run for a long time. And we should think carefully and consider the possibility of a calibrated response to postponing cancer care rather than the total cancellations that we see in many countries. The results of the survey should also increase awareness of potential poor clinical outcomes in liver cancer with some of the restrictive measures. We will see delayed cancer diagnosis, delayed initiation of treatment, and the changing of more efficacious inpatient therapies for less efficacious oral therapies. And in fact, we think that there should be serious consideration for the increased use of digital communication for consultations, which, as we can see, is even possible in third world countries like Myanmar and the Philippines. There are significant differences between SARS and COVID-19. SARS affected mainly hospitals and healthcare workers, whereas COVID-19 affected many people in the community. And the other biggest difference is that the genome sequence for COVID-19 was published very early by the Chinese government within the first month of January, and this resulted in the development of vaccines. And as of 23rd of August 2021, Singapore has delivered more than 8 million doses of vaccine and vaccinated more than 4 million people. And the other consequence of the genomic sequence being publicly available was the development of PCR and rapid antigen tests. And as of 23rd August 2021, Singapore has done a total of more than 17 million swabs. So in summary, the COVID-19 pandemic has resulted in multiple waves of infection, and the pandemic is not likely to be over soon. The strict public health measures that were so effective in our experience in controlling SARS within a short period of a few months is probably not going to be tenable in COVID-19, which will stretch over a long period of time. And the first wave of the COVID-19 pandemic has brought us many lessons, which are going to be useful for the management of subsequent waves. It has told us that a calibrated response to cancer care will be more useful than outright cancellation of services. And it has also informed us that there will be a backlog of cases with late diagnosis coming up in year 2 and year 3. and that the substitution of standard of care therapies for less efficacious outpatient therapies will lead to poorer clinical outcomes, and that there should be increased use of digital communications for consultation. All of this will come in handy as we continue to face further waves of the COVID-19 pandemic. Thank you very much for your attention. I'd like to thank the Duke-NUS Global Health Institute for the support of the study, and also to thank Ms. Sim Yuki for the creation of the slides. I'll be happy to take any questions.
Great. Thanks so much, Pierce. That was a really careful distillation of the data that you received from all over. So it was a really interesting thing. So I encourage people to kind of ask any questions they have in the chat box. But in the meantime, maybe I'll ask you one as you're thinking of it. So, one such an important part of it, you talked about the calibration and how it can still, there are ways to kind of get around when you have this kind of scare of being totally locked down and then maybe not doing it as totally. But this was done in the context of Singapore, where you have very rich data, you have systems, you have your number, basically what's going on in a very precise way. How has it been in other regional countries? Because as you know, we are always interested in what's going on in the region. Is that kind of calibration possible, or how is it possible? How can they work on ways to make that very careful analysis?
I think it will be challenging in some places. You are right. It is more easily done in a place with the systems already available that you can actually track the patients and can postpone them. And I think the absence of structures also impact on the way things are done. Because if you look at our study, the three countries with very high uptake of teleconsultation were Philippines, Myanmar, and Australia. And in Australia, they are used to teleconsultation because they have vast tracts of areas. And in fact, teleconsultation is a normal modality for some of the far-flung patients, you see. But in Myanmar and in Philippines, there was actually very little public control of the disease. And because of that, public sentiments were very unfavorable. In fact, patients do not want to come to the hospital, and doctors do not want to meet the patients. And in these two countries, you can see a very high uptake of teleconsultation. And teleconsultation is actually one way of avoiding a total cessation of care altogether. If you don't even want to meet the patients on teleconsultation, then the patients are really lost. So I think while it is not possible in many places to have a very calibrated approach, I think the increased use of teleconsultation is something that can be done in most places. In fact, even in places that are challenged, because in many of these countries, they've jumped right into the internet age, bypassing a lot of fixed structures. So teleconsultation is possible. But in the more established places, I think to adopt a calibrated approach is also a philosophical approach. I think initially there was very little interest in doing that because everybody hoped that COVID-19 will be over in 6 months. So let's be very strict about it. And in 6 months' time, we will be as successful as we were in SARS. Clearly, that's not the case. So we will probably have to adopt a more calibrated approach as a matter of policy for those centers that can do that, given that some places may be difficult to achieve.
Yeah, that's something to keep in mind, and it's quite difficult. So there was one question that we actually received from the registration group. So I'll read that out to you so that we can answer it. It says, does COVID infection have direct, just reading it, and does COVID infection have direct correlations with hepatocellular carcinoma?
Well, the COVID pandemic has been with us only for a short time of less than 2 years. So at the moment, we can't say whether in the long run, COVID infection will actually make a person more predisposed to liver cancer. There's no data to suggest that at the moment. What we do know of the science is that the COVID-19 virus may have predilection for certain cell types within the liver. And what we've seen is that they may actually preferentially infect the progenitor cells, which is very important. Because as a person gets ill and as part of the liver gets injured, the liver is a remarkable organ and can regenerate to recover. But if the virus preferentially attacks the cells that are responsible for regeneration, then such patients may have difficulty in recovering from any impact on the liver. And that's what we are worried about. We think that some of these patients with COVID-19 may face liver problems because the liver is not as resilient anymore, because the part of the liver responsible for liver regeneration may have been preferentially attacked by the virus. So that's our concern. But in relation to liver cancer at the moment, I must say that nobody will have the data because this is such a short infection. Clearly, people with cancer are more susceptible with a higher case fatality, but we can't say today whether the COVID-19 pandemic has a direct relationship or impact on liver cancer.
Right, like with everything in this pandemic, we are still in a learning stage. So there's another question that's come from, in fact, our SDGHI research associate, and she asked, more pandemics are predicted in the future, and one of the survey data points included past experience and preparedness to pandemic. Did the results suggest any trends that indicated past pandemic response experience helped the cancer care amidst the current pandemic? And also, what are your thoughts on the ways in which we can better prepare and continue cancer screening, cancer care, etc. in the future?
I think the experience of the past pandemics, especially SARS, have not really prepared us to handle cancer patients in the current pandemic. Because if you remember, SARS was over in a short time. And in SARS, we actually don't have vaccines, we don't have PCR, we don't have rapid antigen tests. Everything was due to strict enforcement of public health measures. And it was okay because it was over in a couple of months. So the impact on patients was there, but it was not that serious because a 6-month impact is not as serious as a 3-year impact, for example. So we were more geared towards or more prepared for an aggressive pandemic that can be rapidly controlled by very strict public health measures. So in fact, we have, if you look at the global impact as reported by everyone else, in lots of places, in fact, there's a total closure of cancer service on the assumption that firstly, patients with cancer are more susceptible, so please don't come to the hospital. And we are not going to do diagnostic tests for you to screen for cancers because that actually increases the risk of you getting COVID in the hospital. In fact, we want less footfall in the hospital. So if anything, it didn't help cancer care at all. And the impact of the initial response was very drastically bad for cancer patients and has resulted in delayed diagnosis, which will be with us for the next few years. But I think we learned from that. I think everybody realizes now that the COVID-19 pandemic will come in waves. And overall, there's been greater flexibility on how to manage such patients. And of course, as a bigger proportion of the population gets vaccinated, we are also more ready to relax some of the restrictions, because one of the main concerns earlier on was that if there are many people infected, the hospitals will be overwhelmed. But of course, as you reach 80% vaccination rate and 90% vaccination rate, you can allow some of the screening procedures to happen, because that is how people are diagnosed with cancer in the early stage. So I think our experience from past pandemics have not helped us, but I think our experience from the first wave of the pandemic is now helping us in coping with subsequent waves of the pandemic.
Yeah, so that makes me think about, so first we have these kind of, restrictions coming from externally, and, everyone can't access the hospitals and, the cancer care clinics. Then you have the restrictions are kind of opened up, but maybe in certain cases, you see people themselves are still a little bit nervous to come, even when the restrictions are open up. Where do you think there's an opportunity to maybe have greater education or outreach to patients to kind of at least be able to, manage that aspect of it?
I think public sentiments can be improved from two sources. Firstly, of course, with vaccination. If there is a greater proportion of the patient being vaccinated, and if the patient himself has been vaccinated, that improves patient sentiments, more confidence that you can go to the hospital and get tested. And the second is, of course, the public health system itself. For example, of course, this includes high rates of vaccination. So if the public health system itself seems to be functioning well, then patients have more confidence in the system and they turn up to the hospital to get screened or vaccinated, for example. And this is clearly shown because I think in our study, the countries where there was least positive public sentiment come from the countries where there was the least amount of public health measures. Places like Philippines and Myanmar, where there was really a lack of confidence in the system. People don't want to leave their homes, they stay at home, and the doctors themselves do not want to meet patients. So I think improving public sentiments depends on higher rates of vaccination, and also depends on the public health system being well organized. So in the long run, if these two things happen, then sentiments will improve and patients will get screened, and cancer care can continue with some modicum of normality, I think.
It comes back to that question of trust in the system in many different ways.
Yeah.
So I'll ask another question from the audience. So that is, how prevalent is the non-alcoholic fatty liver being the primary cause of liver cancer in the world today? And is there a significant difference in trend between countries?
Yeah, the non-alcoholic fatty liver disease is now increasingly important as a cause of liver cancer. And previously, we used to think this is mainly a Western problem, maybe a Western diet and so on, but increasingly we don't think that anymore because the prevalence of non-alcoholic fatty liver disease is very high in the Asia Pacific. For example, in Singapore, the prevalence is almost 50%. So while non-alcoholic fatty liver disease as a risk factor for liver cancer is not as serious as, for example, chronic hepatitis B, there are simply very large numbers of such patients, right? And in fact, a recent survey of, for example, surgical resection that we've done at the National Cancer Center for Liver Cancer, we found that up to 40% of them have fatty liver as the causative reason for liver cancer, whereas 15 years ago, it would be about 5%. So over the last 20 years, non-alcoholic fatty liver disease has really become very important, and not only in the West, it's global, you know. And certain ethnic races are more at risk than others. Southern Chinese, for example, patients from the Indian subcontinent, you know, Hispanics in the US, you know, so there is a certain racial predisposition. So there is not a big difference between the countries now in terms of the prevalence, and in the Asia Pacific, we are very vulnerable to this impact.
So that makes me think not, so you've pointed to like some of these ethnic differences, but you know, you have this amazing, you know, span of groups all over Asia, and from there, but cutting countries which are very socio-economically different from each other.
That's
you know?
Right. That's right. Yeah, that's right.
What are the kind of social determinants that really you see have been making a difference? So not kind of going at it from just the science difference, but you know, contextual differences.
I think from the socio-economic point, it is quite uniformly clear that non-alcoholic fatty liver disease is more prevalent among the lower socio-economic class. Maybe they are less health conscious, and it is actually less prevalent among more educated people and the professional classes. Maybe because they are more aware of health and they lead maybe more healthy lifestyles, you know. And this was contrary to earlier expectations, where they think that it is mainly a disease of people who have a lot of leisure on their hands. It didn't turn out that way. So our main concern will always be with those from the lower socioeconomic class, because the prevalence of fatty liver among them is actually significantly higher. Maybe because of lack of awareness, lack of attention to diet, lack of attention to exercise, perhaps.
Yeah, these are the ones that are like impacting every kind of disease.
Right.
Yeah, it's
including diabetes.
Yeah. So we have a question that, are we expecting a tsunami of cancers due to the delayed screening and diagnosis? And how are countries like Singapore and other countries in Asia Pacific preparing for this?
I'm afraid that most of us feel that there is going to be a tsunami of cancers diagnosed at the later stages. In fact, we are beginning to see some of them anecdotally, and the longer the pandemic runs, the worse it's going to become. And actually, I don't think we have any good plans to address that, neither in Singapore or elsewhere in the Asia Pacific. I think we are still grappling with putting the pandemic under control. But but you're right. We have to start thinking about the longer term. Eventually, the pandemic will become endemic, hopefully. But then the effects of some of the things that we are not doing now will hit us very hard further down the road. If higher proportions of the patients are going to be diagnosed with later stage cancers, the cost of treatment just goes up. The efficacy of treatment just goes down. And the impact on the patients will be huge, and that will impose a further strain on the healthcare systems, even as we are recovering from the pandemic. I think this is a good time to start making very concrete plans in that direction, and that was a very good suggestion.
Yeah. Okay, to the next question, it's from one of our research associates, and she asked a little bit of a technical question. She says, going back to one of your first few slides, can you explain how SARS-CoV-2 preferentially affects TROP2 plus progenitor cells, and how was it first detected?
So we detected that because we were already doing research on the liver. So what we were doing is that we were doing single cell sequencing of liver cancer cells and normal liver cells at the same time. And the single cell sequencing, of course, allows us to identify the cell types very carefully and the markers very carefully. And we complemented that with immunohistochemistry of where the locations of the biomarkers are. So of course, when the COVID-19 came about, we quickly take a closer look to the S2 inhibitor, S2 receptor, because that was of interest in COVID-19, and we found the co-location of this because of our ongoing work. So in a way, it was lucky that we were already doing work in that area. So we were quickly able to identify co-locations of the biomarkers, and because of that, there is the very real possibility that because of the high concentration of S2 receptors in these locations, the progenitor cells may be preferentially targeted. But of course, we do not have functional work on this. This is just an observation that we made from single cell sequencing and immunohistochemistry, but something to be of concern.
Yeah, great. So let me ask you, so you've covered a whole lot of points from the scientific point of view. You've also covered things from the public health point of view. If you had the ear of a policymaker, like right now, what will be, your main practical suggestions to them? Like, what do they need to be doing? And it doesn't have to be just Singapore, but really thinking of the.
That's right. I see. Yeah, you're right. I think that the first thing I will suggest is that it's really time to plan long term. Because we have the vaccines now, the vaccination rates will increase. Eventually, of course, we have to convince people to be vaccinated. But we really have to think long term and think of the impact of some of the things we are doing now on the future of our population. And of course, if I were just to focus on cancer care, I say, well, we should restart cancer screening immediately because it's going to be very important. We already have a backlog of patients who ought to be screened and are not screened. We should get them all back. We should start addressing the issues, and we should be prepared that as we restart the screening programs, we are going to discover more patients at the later stages of the disease because of the backlog of cases that we have not been doing. And we have to be prepared that we have to treat them as soon as possible because, of course, if we diagnose them at a later stage and they still have to wait a long time for treatment, it makes it worse, you see. So I think that it has to begin with thinking along those lines that we are now more confident that we can overcome the pandemic because of the vaccines and other therapeutics. It's time to think about making good some of the things we have not been doing, because otherwise it will hit us very hard in the coming 2 or 3 years. So that's what I will tell them.
And I hope they're listening. I hope we can get some of them to listen. Okay, do we have any other questions from the chat, from our audience in the chat? I don't see any new questions. So maybe a few minutes before time, I'll say a big thank you for being with us. That was very, very, educational. I think the value of those clinical trials and those groups and networks you already had in place was clearly demonstrated, and how you could tap into that to kind of go forward in a very short way. So, from our global health perspective, that's a great kind of model that we hope that people across the different disciplines will be developing. And thank you to the audience. I hope you enjoyed this. Please tune in last Friday of the month for our next Global Health Seminar Series. You'll be getting your emails, and we look forward to continuing these conversations with all of you. And thank you, Pierce.
Yeah, it's a
And
pleasure. It's a pleasure.
And thank you to our team who helps put this all together. It's always a huge team effort, and I think they do a marvelous job.
Have a great weekend, everyone.